First of all, let me congratulate the PSNM officials, especially Dr. Shazia Fatma, for putting such a good show and providing me this opportunity to talk at this late hours of the day. And I appreciate all those who are still here and attending the session. So I'll be talking briefly about theranostics in pancreatic Gastro Entero Pancreatic Neuroendocrine Tumours because we have recently started some theranostics at our institute, so I wanted to share those experiences along with some perspective of the disease as well. So this is the institute where I work, as Dr. Arzu Fatma mentioned, the first institute in the province, and it has been now almost 50 years that IRNM is serving the people of the region. Now, the radionuclide therapies, as all you know, that it's expanding, and when I used to teach radionuclide therapies in PIAS some 20 years back, it seems fairy tales at that time, and most of my fellows used to ask me, would it be possible that these things come into practice in Pakistan someday? And today, listening to all these talks and having lutetium-based therapies available, now I think that dream has come true. And now we understand the disease pathophysiology much better, and there are lesser complications, as we know, with radionuclides used in therapeutics as compared to the conventional modalities. And then we have longer survival due to better clinical and critical care at our oncological setups. So we are having these radionuclide therapies more popular. When I did the PubMed search last week, so I found that for theranostics, there were almost 20,000 publications in the last 1 year. And if you look at the trend, it is ever increasing. And the 2023, still there are a few months left, so it may overtake the 2022, hopefully. When you compare, when you give a search of theranostics in oncology, still you get around 9,000 papers in the literature of the PubMed. So I'll be briefly talking about the Gastro Entero Pancreatic Neuroendocrine Tumours, or GEPNETS. Its pathophysiology for those who are new in the field, of the somatostatin receptors, and what are the treatment options. These GEPNETS are 70% of the total neuroendocrine tumors, so they are the commonest of all the neuroendocrine tumors, and they originate primarily from the small and the large intestine, rectum, and pancreas, of course, but to a lesser proportion. The overall statistics are not that clear about GEPNETS, but it's estimated that around 4 to 5 per 100,000 new patients are diagnosed in the Western population. And this is the incidence, but the prevalence is increasing because the patients are now living longer with their diseases. So the incidence is remaining stable, but the prevalence is increasing and over time due to better clinical and oncological care. This kind of a disease, these GEPNETs, they are diagnosed very late in the course of the disease because they initially visit primary physician for their vague symptoms, then they are referred to multiple specialties, and usually imaging is ordered later in the course of their diseases, and it takes around 5 to 7 years on the average to get the diagnosis after the start of the symptoms. So histopathology, proven neuroendocrine tumors are diagnosed very late in the course of the disease. By then, they are metastasized. So we have to keep in mind few things related to GEPNETs. One is we have to identify whether it's a pancreatic or a non-pancreatic GEPNET. Is it functional or non-functional, whether it is secreting some hormone or it is not secreting hormone, it is slow growing or it is fast growing, whether the cells are accumulating somatostatin receptor analogs or they are accumulating the FTG. So I'll be talking about how to decide about the treatment option, especially when it comes to PRRT. Now, the degree of differentiation is very, very important when you are employing the radionuclide therapies, and the Ki-67 index help us in understanding the proliferation. And if the Ki-67 index is less than 2, we consider this tumor to be well differentiated. If Ki-67 index on histopathology is between 2 and 20, we consider this tumor to be intermediately differentiated and grade 2, and further, if more than 20, we consider it G3 or grade 3 disease. Various receptors are expressed on different cancer cells, and same is true for the neuroendocrine tumors. They exhibit a large array of receptors and proteins on their cell surfaces, but what we are interested in is the somatostatin receptor, and these somatostatin receptors will be binding our analogs and the radiopharmaceuticals. In cancer cells, these somatostatin receptors are overexpressed, so make them a target for the theranostics. So these somatostatin and somatostatin receptors need to be slightly elaborated. Somatostatin exists in two isoforms, the short chain and the long chain, and the short chain are 14 amino acids and the long chain is 21 amino acids, and they attach to 5 subtypes of receptors, and the things are more complicated when it comes to which tumor will be targeted, which tumor will be exhibiting which kind of a receptor. So this is summary of the picture of the types of somatostatins, and in the lower panel you see all the synthetically prepared somatostatin receptor analogs. Now, in simple words, in theranostics, what we do, we take a molecule shown in the red in this image that would be attaching to the tumor cell's receptor, while the blue schematic diagram is showing the linker which will link the radiometal to this biomolecule. So this is a simplest form of description of how the theranostics work. And the attachment to the tumor cell would depend on a lot of factors. As Dr. Irfan is here, he would be he's the master in preparing such radiopharmaceuticals at his labs, and there are a lot of things which need to be considered related to ligand, related to the radioisotope, which ligand should be used, which linker should be used, and then there are factors in the patient or in the target, like how it has to be transported, what are the binding sites and the concentration and the retention at the tumor site, and then the pharmacological intervention. If some concomitant pharmacological intervention is also being done, then it will enhance the efficacy of these theranostic efforts. There have been a lot of isotopes and a lot of radiopharmaceutical tried in these GEPNETs, and ultimately the lutetium labeled dotatate made its way to the clinics, and now we'll be not complicating your life further with the chemistry and going to the receptor. So the receptor for the somatostatin is has got three subcomponents. It's a G protein, and it has an alpha, beta, and a gamma subunit. And these are some of the diagrams of these, and these are the various types of receptors and the affinities of gastrinoma, insulinomas, and the non-functioning pancreatic tumors and the carcinoid tumors with all these receptors. But we are not treating statistics, we are treating patients. So what we do, we try different kind of ligands in the imaging, and whatever ligand is attaching to a particular receptor, then we would be using that rather than looking for statistics. So this is how a somatostatin reacts with a G protein at the receptor site. It activates the receptor, and the alpha unit separates from the beta gamma complex, and it activates adenyl cyclase, phospholipases, and various kinases, and the tumor and this complex, when internalized, may upregulate or downregulate the receptors on the surface. So this is how a tumor, the isotope is getting into the bloodstream. Then it is accumulated and it's taken up on the surface by the receptors, and then it is internalized in the vesicles, and inside the cell it destroys the cell when it is inside. So different kind of isotopes have been employed. The isotopes which are low energy would deposit their energy in the near vicinity, while the higher energy beta emitters would be having more collateral or the crossfire damage, while the alpha emitter would be delivering the dose in the near vicinity. So various efforts have been made, and we also commend the efforts of INMOL in this regard, and they have been the pioneers in starting theranostics in Pakistan, and Pakistan came onto the map of all those countries which are employing theranostics, and we are lucky to have friends everywhere, and especially at INMOL, and who will be supporting other centers now to start their efforts in the theranostics as well. And IRNM has taken few steps, and we would love that these efforts may be further strengthened and these services may be extended to other centers as well. This is one image where you can see a lot of activity all around in the mediastinum, in the liver, and then this patient was, when treated with lutetium dotatate therapy, this is also an image from INMOL, is a very historical image, and it got the recognition from every corner of the country. Now this slide is slightly important for those the beginners. Like if the what we call differentiation, degree of differentiation is very high, the tumor would be more octreotide avid, and if the tumor is more undifferentiated, it would be more FDG avid. And this is an example of such a patient where you can have a very high FDG uptake in the liver, and you see the Ki67 index is 20, but you don't see a lot of activity on the dotatate image in the same patient. Similarly, here the Ki67 index is 2, so you don't see any FDG avid tumors, but you see a lot of dotatate foci, dotatate avid foci in the other image. So keep in mind these 5 points when you plan to treat a patient with lutetium dotatate. That is, the grade of the tumor is very important. Whether the tumor is progressing or not, if the tumor is not progressing, it's better not to treat those patients and to treat it when the tumor shows signs of progression. Then the functionality, if the tumor has got potentials of producing hormones, and that hormones are causing symptoms to the patient, then these tumors need to be treated. And then the burden, if the tumor burden is too high, then you may you may opt for therapies. And then the comorbidities. One should not sit all the class fellows in one row, because then they'll be talking too much. So they should be made to sit in different corners of a hall, and they are not even listening to me, like I'm talking about them. Yes, so you all class fellows should sit in different corners of the hall rather than sitting together, because and especially when they are female, there should be some yeah, but you are gents, you see, that's the difference. So, sorry for the gender biased statements, but yeah, I would have been sitting with them. Okay. So this is another case of 54 years of age male, and he has got a very high urinary 5 HIA, and it was biopsied, and it was a neuroendocrine tumor, and you see the regression in the disease in this case. This is an image from Iranum, and this was the first patient that we treated, and after 4 treatments, still you see some activity there in the liver, but the uptake is very good in the initial images and the subsequent images. Still after the 4th dose, we had activity, but this patient was in a very, presented in a very moribund state, and he was in the wheelchair and on the bed. But after and he had a very high bilirubin levels. He had obstructive jaundice, and now the bilirubin levels has significantly, drastically reduced, and patient is up and about and doing his normal routine activities. And this patient was also interviewed by a worthy chairman, and he was asked, and this is when we took the picture when he was meeting the chairman on an online meeting. This picture has been taken and presented here with the consent of the patient. This is another case, and you see a wonderful uptake of these. These are all Pinstec produced radiopharmaceuticals. So I congratulate the team Pinstec and the IPD, including their head technology as well, Dr. Wasim, and Dr. Nadeem Lodi, for being with us all the time, providing us all the support, and the response of all the patient was objective response, and the quality of life significantly improved. But as you see, all these patients presented very late in the course of the disease, and the tumor burden is too high. Let me show you another case that will open your dimensions more. Like if you see so huge tumors, then how can you expect that they'll be treated with 3 or 4 or 5, 6 doses? So that is why I was asking Dr. Rizwan in the last session that should we think about escalating the doses and about other. So we may plan to have yttrium as well. So Nadeem, think about yttrium for such big tumors, because the lutetium will not be very effective in such big tumors, and we would be needing some high energy beta for such patients. So this is a very famous curve everywhere shown in the NETTER-1 trial, and I won't be going into further details. And just to emphasize, the quality of life in the NETTER trial was discussed, and it improved significantly, and this kind of treatments should be further explored, because most of the time behind every radiopharmaceutical there is not that big commercial motive as we have behind a lot of pharmaceuticals which have a commercial motive behind it, and they are promoted in that way. In radiopharmaceutical, unfortunately, when some people who are implying that treatment, when they are away or when they are not in their commanding posts, then the things go into the back burner, and the efficacy on one part, but these things are not that much in use after they go from that place. So I would be more interested in sustainable development of such therapeutic agents from the Pinstec, and they should treat these lutetium, and they should be looking forward to many, as Dr. Shabana in her previous lecture elaborated, that there are many things to come, especially the alpha emitters. And I wish in my lifetime we see some alpha therapies as well, inshallah. And that would be another dream coming true, to see alpha emitters. And I'll conclude my talk with one more suggestion, that the medical physicists need to be further engaged into the dosimetric processes. They are very much reluctant into the internal dosimetries. For almost in every medical center, we have got multiples of physicists available to us now. Prese is producing quite a significant number of medical physicists, and they are there in our department more than the doctors. I had 6 physicists in my Sinor center, while 2 nuclear physicians, including me. So this medical physicists are too much, but they are more interested to work in the radiotherapy department. So the internal dosimetry should be more, and I request my worthy colleagues from Prese that help us in calculating and in doing all these. Yes. Okay, so this is just to emphasize on this forum, and I'll just, the algorithms are very simple, as they look very complicated on this slide, but you have to choose all those patients, you have to separate all those patients which are operable from those which are inoperable. Then the inoperable, you should look for those patients who have got a progressive disease or a hormone producing disease, and those can be referred for PRRT. So these are very promising tools in the management and care of selected patients with inoperable metastatic neuroendocrine tumors. Symptomatic improvement does occur in all patients. Even in those patients, the trial have been done, G3 patients, in those patients symptomatic improvement have been documented. The yttrium and lutetium results are very encouraging in terms of tumor regression. Kidney protection is very important, and one should be very cautious about the kidney doses to the kidney. We have a patient who have got a single inoperable but single lesion in the liver, and we are hopeful that he would achieve a cure. But the problem is he is excreting too much of the, like in multiple tumors, most of the tracer is taken up by the tumors, and little is left for the kidneys to be excreted. But if the tumor is small, there is a chance of a cure, but at the same time, a lot of medicine would be excreting and delivering a dose to the kidneys. So the kidneys' safety is of immense importance. And then comes to the self-assessment questionnaire, quality of life. The lutetium has done wonders in this regard as well. I'll just briefly touch the future. In the future, we should look for alpha emitters in selected patients. Then antagonists, the somatostatin receptor antagonists are known to bind tightly to the target, and they are retained for a longer period of time. So they are also considered adjuvant therapy with the consent of and with the help of an oncologist. Dr. Asghar is here, and they can guide us like which kind of adjuvant chemos we can give along with the lutetium dotatate therapy to enhance the efficacy of these. Some are capecitabine or temozolomide have been under the trials. And then intraarterial injection directly, like we had a big tumor, the huge tumors in the liver in one case. I think those were the candidates for the direct injection into the intraarterial. And then immune check block points along with lutetium dotatate. And then there are certain off-label uses. I won't go into the details of them. So thank you for your patient listening. This is our 20th Center of Pakistan Atomic Energy Commission, where nuclear medicine has reached the northernmost frontier of the country. Thank you for your patient listening. Thank you.